theme of this conference, Protocols and Practices. Sunil and I, we're going to do this together, but Sunil's going to be active from the floor. I have to create a lot of the slides Sunil has put together for this panel. Now the idea that we had was that we all know that CIGI has protocols, practice guidelines that have been in place now for about 5-6 years. Practices have evolved. The scenario in our country has changed, it has evolved, and I think it's fair that we all look at the clinical practice guidelines that we have and see if we need to revise, modify this sort of practice. So the idea is that we will take up some of the issues. We cannot cover the complete clinical practice guidelines in 45 minutes. We might look at this as an initial brainstorming session and take it from there. So what we've done is that we have taken excerpts from the guidelines and we'll cover some of these topics, and this might be food for future thought and development of newer guidelines, if you like. So we have our esteemed panelists here. We've got Dr. Madhuri Gore, Dr. Mohanty, Dr. Asha Yatraj is here, Dr. Kapil Sikka, and Shweta Deshpande is here. But I think Dr. Patil is not here. Is that correct? Yes, so we don't have Dr. Patil. So we have some audiologists, we have a couple of surgeons, and Patil was from the ADIP scheme. We thought we'd get that input from there, but they're not here. Okay, so this is how we plan to run this, and we'll see how much. Welcome. Please come up. Thank you. Just made it in time. Wonderful. Thank you. Okay, so that's the skeleton framework, and depending on the time that we have, we'll see how far we can go down this list. So we thought we'll look at the guidelines. We look at how our practice is developing or currently in place. We look at the team personnel criteria, the training mentorship criteria, infrastructure requirements, candidacy, and we'll see if we can touch upon the situation with the state government schemes and the ADIP scheme. And if we have time, then we'll try and see if we can brainstorm on the hub and spoke models for satellite centers. So, of course, the criteria starts with the various protocols and preoperative checklists and things like that, and we've got radiology and vaccination. It brings me, I'm going to skip through various things, so because we have only 40 minutes, so we're just going to pick up a few things that we thought are relevant. So first is the vaccination protocol. So currently the vaccination protocol that we have recommends that every CI implantee is vaccinated against pneumococcus, H. influenza. It says meningococcus, but it's not in the list. So, which clinician would like to touch upon? Kapil, would you like to touch upon the vaccination protocol as it stands today? It's up on the screen. And do you think that this is appropriate, or do we need to modify it? What is the situation with the H. influenza, and should meningococcal be mandatory?
Personally feel that meningitis as a complication of CI is overrated, but till the time we get any personal experience-based guidelines, I think the guidelines stand. We should vaccinate the patients for pneumococcal and Hib today, and no need specifically, if no other indication stands, then for meningococcal no need stands.
I think we have to remember this is the CDC guidelines, and that's what I think it's imperative for us to follow the CDC guidelines. Dr. Mohanty, anything else you want to add?
I think we should continue with this as you said, with meningitis as an entity, and it's not really associated as such, so it's better that we still continue with the same.
How soon should the children be vaccinated? We don't have that. Figure there. Is it a minimum time duration, and how practical is it to follow the minimum time duration, the minimum period prior to surgery for vaccination?
we do it at least a couple of weeks minimum, 2 to 3 weeks before, so that we are sure of the time frame.
2 to 3 weeks. May I take the liberty of maybe asking questions from key people in the audience as well to get varied opinions?
Could I make a comment? This is not, obviously I'm not doing the immunization, but these are patients who come from other centers, and particular surgeons don't give any form of immunization. They claim that they have over close to 1,500 cases. They've never given immunization, and they've had no issues at all with the patient. So we've got about 10, 12 of these patients, no issues with them, and they've not gone to any immunization.
Yeah, I think that we've seen that. That's why I brought that up, because we see this quite often. Is that lots of colleagues don't make it. They don't think it's mandatory to vaccinate these children. I think we've got to have a system to ensure that these kids are vaccinated. Sunil, you want to say something?
Yeah, I just wanted to reiterate what you said. There is this other technique that people talk about where the mastoid is not being opened, so there is no risk of meningitis, and I don't know where that science or logic comes from, and hence no immunization. Some of them, not all of them that do that technique talk about it, and I just wanted to bring that up there. And yeah.
Okay, quickly.
Just very quickly about HIV today. It's going on now with anyway the UIP, immunization program.
It is a universal program,
yeah.
yes.
So you do not get a separate HIV available. It's just one company, and even that is going off the market. I just wanted to bring that up.
So it's a part of your the pentavalent thing, and the meningitis has nothing to do with mastoid. It's because these are children, they are not adults, they are prone, they do get acute otitis media sometime in their post-operative course or even later on, and that streptococcal or pneumococcal infection is responsible for meningitis. It's not the mastoid that leads to meningitis. They should be vaccinated till we get good relevant data that it is not required from Indian setting.
Simon, I'm sorry, I'm going to be picking your brain quite often. You see, a lot of our guidelines, because the likes of Sunil, myself, some of us who trained in the UK, and then we came over, the people, the teams, a lot of the senior people here who started the guidelines for CIGI, we took a lot from the CIGI guidelines, yeah. So, but they may have changed as well. So I'll keep picking your brain to get some input from your end.
Actually, it's quite timely because at the moment we're having trouble getting the pneumococcal vaccine in the UK. So we're just having a debate in our unit about whether or not we should be implanting these patients until the vaccine is available again. And I think we've decided that we will go ahead and implant them based on the fact that it's extremely unlikely that they're going to get meningitis. And we actually haven't had any cases of meningitis secondary to a cochlear implant, except for maybe one, and even that is debatable. So I think the vaccination all comes from previous types of implants
Yes.
that are no longer on the market, and we're being very cautious. Personally, I think we should be immunising anyway, because if it was my child, I wouldn't want any risk of meningitis. But I can totally understand why people are asking the question about not doing it. I think we should.
Okay, so we should, as far as possible, unless we're really stuck and we don't have the vaccine, and that's going to land up wasting time, or some certain situations like meningitis and stuff like that, where you may not have
What
time.
about the post-lingual patients?
I beg your pardon?
What about the post-lingual patients?
We're talking about children here.
No, but
Postlingual also need pneumococcal vaccination, but meningococcal is not required, and hip is probably not required for postlingual. But there are criteria and there are guidelines. We have a checklist available in our clinic, and we refer to that. I am not often remembering, but yes, pneumococcal is required for postlingual also.
Okay, we'll come to the clinical personnel. So we'll discuss surgeons, audiologists, habilitation, and this is what we have, right now. Surgeons should have a postgraduate qualification in ENT, of course, an MS or DNB, and 5 years qualification. We've got figures. These are sort of figures, that arbitrary figures, I guess, or some thought out figures of the number of surgeries, operations, stay-piece surgery, attendance at workshops, observers, participation in X number of CI surgeries. So based on when teams are coming together and we are recommending surgical prowess, or, criteria, again because it's surgeons, Dr. Mohanty, Dr. Kapil, you have any thoughts on whether this is appropriate? This should we be so dogmatic about it, or is it a very subjective situation?
Okay, here I will take a couple of minutes. When you said 500 tympanomastoids, it depends whether it's assisting, under supervision, independent. We do not know at what level of training they have gone through the curriculum. That's one thing. And who are the mentors who are actually supervising them? How are they? I mean, it is all speaking the rhetoric, but that is the most important issue in today's world when we're talking about implantation. And just having somebody to just oversee what he's doing and what's not, without going through the formal training of temporal bone dissections as such first, and going through the rigmarole of all the middle ear surgeries first, and then you think of anybody passing out, I won't name them, but just passing out because they have the umbrella cover of somebody who's already trained in cochlear implantation. They just slide in without even doing even 10 mastoids. So how do we do that? That's the only question I would give it.
Yeah, so the question is that can we control, should we be controlling for that, and how does sort of one, come to a decision or a conclusion that, a person is probably ready to move to the next stage and embark on cochlear implant surgery or get training in
Future
cochlear
of
implant
that
surgery?
should be certified, structured fellowship programs, which
By whom?
which need to be certified and ratified by as many reputed organizations as possible, maybe
Such
Medical
as?
Council, Cochlear Implant Group, Association of Otolaryngologists, and maybe many more.
Can I make a suggestion here? The team which starts rather embarking on such a venture, at least a surgeon should have at least, if not more, forget about the 500 surgeries on live patients, at least temporal bone dissection certification should be there. Because that probably in the CIGICON that we have a pre-conference here, or somebody goes outside the country to have formal training, somewhere some certification is required to really get into it, otherwise anybody's game into it.
Yeah. I mean, I must sort of emphasize here that while we are discussing guidelines, CIGI is not a regulatory body. So these are recommendations that we as professionals are coming up so that newer professionals, developing professionals can understand what's required. So at no point are these regulations or these discussions, these discussions or recommendations, a mandate or regular. So that is a disclaimer that we must make, because that has come up, that these are the guidelines, and if people don't follow the guidelines, then we can't do it. But we are not regulatory. So please do keep that in mind. But this is good clinical practice guidelines, and what I would want that a junior surgeon should have if he or she was to operate on my child, for example, or somebody I knew, or any other child for that matter. And same for the other clinicians as well, so that we have a certain standard of care that we can maintain. Can we come? Manoj, you want to say something?
I was thinking that as a surgeon, when you're training somebody to do surgery, you're vicariously liable, aren't you? I mean, that's something that we should never forget. See, imagine that if somebody is doing ECI under my training, I am a person who is vicariously liable till I can say that he's all right. And that's something that all of us forget. Responsibility and liability. So if somebody that who I have ratified to be a good surgeon has got a problem in the surgery, I am supposed to be there to correct it.
No, that's true. Yes, if you're training, that we are responsible for the trainee and for the mentee.
Yeah, mentee. So
That's right.
that's not a bad thing at all.
So I think the issue here is about the quality of the training that somebody is going through, rather than necessarily just numbers. Yes, Shifali, you want to say something?
I just have a follow-up to what Manoj is saying. I agree with what he's saying, but I'm just taking the flip side of the argument, where what about, because this is going to happen as numbers increase, what about in any discipline, if anyone is mentoring a group and some in that group don't make it, what happens? What happens? What should we be doing?
So your question for the audience is that you first said you agreed with what Manoj said, you looked at the flip side, and the thing is that if you have a group of people whom you are mentoring, and there are some in that group who don't achieve a certain standard, then what should you be doing about it? Is that what you're asking?
Yes.
Yeah. But can we as mentors actually, we can do anything about it? Again, can we?
See, I'll tell you one thing. I think I understand this whole thing about being not being regulatory. But I think as a group of professionals, we have to have some more than just a conscience, because that's the only way we're going to be able to affect the quality of outcomes.
Just to say, without mind, I know I met a certain and every company has their mentorship checklist for the mentee. I don't know if there is a reverse also, how good the mentor is, but the mentee checklist that we are given to assess the mentee has several things. So you decide 5, 10 surgeries that you want to mentor. And then I know this mentor surgeon who has knocked off, I'm not done so yet, but I know this mentor surgeon who has knocked off 2 of his mentees. And that's it. So I think the onus is on us. Well, I'm talking about you. So Manoj has done so with 2 surgeons, 2 mentees. So yes, it is our responsibility.
So how do we ensure that surgeons get training? I think there are adequate opportunities for surgeons to train. There are pre-conference workshops that are being organized by CIGI itself. There are lots of other otology, advanced otology, CI workshops, and the numbers are increasing across the country. And these are all opportunities. So if somebody says he cannot train or doesn't have access to training, then that should be really looked at. With a lot of doubt, because there are opportunities. Now, do these CIGI hasn't done that so far, but do these workshops need to be CIGI approved, or is it okay if somebody has attended a few temporal bone? You mentioned temporal bone workshops, so if he's been to a few good centers, he's done a couple of temporal bone workshops, and would that be okay for that person to feel empowered? Because CIGI hasn't gone down the route of approving or disproving any workshops at CIGI apart from its own pre-conference.
Just a suggestion, it could be taken in a proper spirit. Just as we have something like the mid-season AOI meets or something like that. So why don't we have something like a CIGI, not sponsored, but CIGI related CI programs over the country, maybe 3 times a year, 4 times a year in different parts. That would probably solve the issue straight away instead of waiting for just one conference in Daman or Visakhapatnam to come for the pre-con. I mean, that will at least spread the word that
there are lots of other existing workshops that are happening as well out of CIGI, and we are not saying that it has to be CIGI ratified workshop.
I'm not saying that, because this is a very niche organization which is a part of otology, so which is concentrating only on cochlear implantation. So why don't we I mean, this is just a suggestion.
Yes, ma'am.
Just like you talk about mentorship for surgery, the same thing should happen with audiology also. The mentor is not a trained person, and the mentor is, so you talked about is the qualification of the mentor. I think that's very important, because certain companies have the mentor who doesn't know anything much, and she is training the audiologists who now obviously don't know anything. So that's happening a lot.
Dr. Asha, we are coming to that in a minute. Oh, yeah. Just before that, the reason I put up the previous one was Dr. Kirtane, Dr. Mohan, they run their own workshops. But there are workshops happening around the country, audiology workshops from Aish or Ish, for example, or temporal bone workshops from other surgeons who have actually physically applied for a CIGI approval to the EC. So the EC has been confused in the past, can we approve this or not? So we have not done so yet. Should we, was the question. If an application comes in for a CIGI approval for their institute.
I think, when we apply for any workshop, we ask for RCI because they are the regulatory body. So that's where we get our...
Apart from that, that is your accreditation points. This is as a CIGI approval. This is an academic organization. If they ask for it, we are not asking. If they ask for an approval,
I would say no. I'll let Madhuri say.
Why not? Why not?
I would say yes.
We don't have guidelines, what should be in the workshop.
No, we don't know.
CIGI
This
doesn't
came
have
up, but
guidelines.
we don't currently have guidelines as what should be the curriculum for the workshop to be CIGI approved. I mean, I may decide to do a workshop with one temporal bone station and 1.5 hours, and Manoj, you will do a very nice workshop, state of the art, and with 3D and stuff like that. And both of us may get approval, but the standard of training that's happening is completely different. So unless we as a body have some sort of a recommendation as what should be the minimum criteria in a workshop, a number of days, the curriculum that it covers, then it's going to be very difficult to to create a standard, because then that's going to be a standard that this is a recognized workshop by CIGI or any other body.
We also had some situations that people asked for ISHA to approve. So ISHA is not a regulatory body. You get into trouble like that if you approve. So we can say they are following our guidelines, that's all. You can't say what is in the content, what is in the...
So that's why we haven't done it so far. So in the last,
You can hold it under aegis of CIGI, and the making guidelines is not a difficult thing, sir. I think it is very much doable.
Well, it's not making the guidelines difficult, but applying the guidelines very difficult. I mean, I may tell you tomorrow that your workshop, I'm sorry, does not have this particular instrument or this particular curriculum.
Then you don't approve that. You don't approve that. Simple.
It's going to be a very slippery slope that we're going to be going down.
No, but I want to
CIGI will go
take
to
on from-
verify that whether they have that facility or not. So that becomes an issue again.
It's going to be a practical issue.
Then
Then
again,
we'll
we're
have
back to
somebody's
being
going to have
a
to come and
regulatory
make
body.
sure.
Sir, I applied to MCI for credit points. We apply with the scientific program and maybe biodata of the presenters. They don't come and check with me कि आपके पास hall है या नहीं है. They ask me how much seating capacity do you have. No representative is coming and checking that.
But
MCI would have already come and visited your institution to see whether you have all the facilities. So MCI is already a regulatory body. RCA is our regulatory body, so they have checked to see we have the facilities.
They have mechanisms
so
in place.
So they know that.
I mean, I believe the inspector was here yesterday for the local state points. And he came and he inspected and he saw how many people, that's the way it should be done. If they don't do it, then that's their fault. But we have to be open to scrutiny.
Just one more point, I just had this MCA inspection for the increase of seats and all that. And there is a particular column there, how many cochlear implantation have you done? It's an asterisk. I mean, it's not mandatory, desirable. So when it is already taken into the form, in the form of the MCA inspection form, I think it's probably there in the back of the mind to just get it decentralized all over the country. I have no idea about it, but it's there. So.
You're not allowed to do these surgeries without adequate training. So I just wanted to know, any of the established CI centers, are you planning to have a university certified implantology fellowship courses in the near future? Because I had a difficult time getting my placements.
We have fellowship where it's
certified, university certified, sir. So I'm just aware of Vellore and Murph. I just want to know that.
So in the last 2 years, we've had an implantation otology fellowship certified by Rajiv Gandhi University of Medical Sciences in Karnataka, in Apollo, Bangalore. So I think there are about 4 or 5, if I'm not mistaken, surgical university recognized, university accredited fellowships across the country. We'll make it available on the CIGI website for you guys to apply to. Yeah?
And I think all the established centers, clinics, we would encourage them to try and get university approvals and things like that, so that there are more opportunities of a certain standard, shall we say, that people have access to, so that if the science is spreading, then the science is spreading at reaching a certain decent level. That's the whole idea. We want more people, we want it to spread, but we want to maintain a certain standard. So there's this issue about the mentor surgeon. So this is in the guidelines as well. The mentors, this was there at that time. This was early days again, I guess, that mentor should be approved by the company and should have done certain number of surgeries. So surgeons, what are your thoughts on that? I think the nomenclature for approval was probably incorrect. I think it's not that they have to be approved or had to be approved by the company, but they had to be surgeons who were familiar with the use of that particular device. So I think we need to make some alterations there. Any comments?
50 CS surgeries, well, with the number of surgeons increasing by the day, and seeing the plethora of surgeons mushrooming everywhere, I think that's a little higher number.
So should we have a number at all, or they should be?
I think it's not about the numbers. I mean, if,
Again, it's about quality. So it's
if somebody comes out from abroad and just starts to practice in India, he won't have a single surgery of
No,
CI.
this is the mentor surgeon.
I understand, Sunil. Talking about 50 CI surgeries is written where in the first line. Where? In abroad, in say New Zealand or Sydney or in India. We haven't specified that. What I'm trying to say is a graduate who graduates out of India, very few of them get opportunities to go out and just sharpen their skills. When they come back and they want to restart after say a stint in Middle East of 10 years, 15 years, and then they have a certification. I've already done 365. I'm just giving an ad hoc number. How do you look at that? Yeah. So if it's a log certification, or if you come back to India, I think the number should not be there. As a mentor surgeon, it's understood they're experienced enough to really have some mentees around.
Yeah, so it's not the number that's relevant, and certainly it's not approval. I don't think it was ever meant to be approval by the company. It was meant to be that they should have used the device, but then and companies, I guess, now don't have says to approve or disapprove who the mentor is. Sunil?
That's exactly what the Times of India put up. Mentor should be approved by the company is what the CIGI says, and they had a big grouse about that, and that's one line they picked, and we have repeatedly said so in the surgeons criteria, in the audiology criteria. I don't know about habilitation, which Shefali did, but I think we should knock that off, and we should just knock off this should have all over in the wording. I think we have that repeatedly coming up, and we should reword it. Yeah.
Yes. The other thing that, in terms of mentor, what I would, sorry, you want to say something?
What is desirable would be a better.
Yes, desirable is desirable.
I think in SASThan, I think it has come down to 25. ADIP scheme and in SAST it is 25. So
Yeah.
that's also another comment that
Yeah,
came
so,
in.
so the other thing that I think it would come in later when we're discussing the government schemes, but if you look at all the various criteria that have been to be done under the guidance of the mentor surgeon, so even if he's, that's also important, so that even though I feel that I'm adequate to go solo, but my first few, operations have to be there under mentorship, because you never know what might happen, so I think that needs to be there. So let's move to audiology. Ladies have been, sorry? Yes, ladies and gentlemen.
Just before that, the previous slide, please. Guardianship. The difference between mentorship and guardianship. Guardianship is when you have made your mentee an independent surgeon. He's on his own. You've supported him for 12 surgeries, and then he's on his own. When he makes a mistake, are you owning up to it because you mentored him? Or it's the onus is on himself? Or when he has difficult cases, should he be told, this is anyway guidelines, should we include that he should call the mentor to support him for the surgery? Hence the word guardianship there. Some thoughts on that?
Technically, mentorship should be a lifelong commitment. It's not. It does not end at 10 surgeries or 20 surgeries. But yes, if I feel that I am independent, I am doing an operation, I'll end up in trouble. I have not informed my mentor, then it's my responsibility. I cannot hold my mentor who is sitting in US or England to be responsible for what I did. But yes, it's a lifelong commitment. If I have an abnormal ossification or a aberrant anatomy or a difficult case, I should again call the mentor, or at least do it under his guidance.
Just to add to it, don't we do that for even difficult stapies? It's the same thing.
Yes. Okay. What about in the large number of the government programs?